Hello, doctor. I'm not using any names, your name, or the patient's name for privacy concerns, and because I may want to post this communication because I think it's an interesting case and an interesting philosophy I have. I'm also sending this to some of your colleagues at the office who do Invisalign. The left is where the patient started. And so, is this how she started? Yes. So, what we had was lower crowding, and notice the inward leaning of the teeth. Not all crowding has that, but here you can definitely see a marked inward leaning. This is quite often a compensation for class 3 patients where the teeth have sort of learned to lean back a little bit, not just prior treatment, just genetically. In young kids who are 7 or 8 years old, I can notice that sometimes, and already that compensation is starting. And then on the top, first of all, you notice that we have very little overjet. You can almost call this edge to edge, and this will certainly lead to wear and chipping. This is a young woman already. There's some wear on the teeth, and not too much on the anteriors, but basically you can see how this tooth was in crossbite. The canine was rotated. Now, so what I did in this case, the left was my original projection. I broadened things out somewhat to line them up, and I also did some interproximal reduction. And here's the key point of kind of this video is that in order to get the upper teeth to come forward, which allows me the clearance to bring the lowers forward, not only did I round out that upper arch, but I actually created some space, or planned to create some space distal to the canines, because the patient has a slight class 3 tendency. So you can kind of try to get away with that a little bit. And so the other underlying issue as to why you need space here, you can look here. This is the Bolton analysis, and it shows a mandibular excess of almost 2 millimeters, and in the anterior, a 0.6. So here, this actually totals a millimeter here. Now, here's where we are. This is what's important now. So I've done a few refinements. So I have some distinct clearance now, which is great, I think, to prevent the wear a little bit. I have beautiful lower alignment. So this is, again, this is not the end. This is where she is now. So this looks great. The upper looks great. Now the canine is still rotated out a little bit, and I have that space of 0.3. I had planned for it to be 0.5. This space will not be visible to a patient, and it really doesn't collect that much food if you have it beyond at least 0.5. Here, she hasn't had a problem with it. If you have a tiny open contact, that really can wedge food. Now, you may notice the canine also is tilted a little forward. The original plan had it moving a little bodily, but because I mesialized it, it kind of did lean forward, but that's okay. But here's what I want to show you. The lateral incisor, you can see, obviously, it's not an occlusion, and it is a cosmetic concern of the patient. And I knew it would be. I did have a plan to bring it down with an attachment, but two issues with that. A, it's very hard to do, even with an attachment, because it's such a short, flat tooth. And it's also not a super stable movement. And also, it's actually not, the tooth position isn't the problem. It's the tooth length. Look at the gingival margin. Granted, it might be a little higher here, but it's much shorter here. So if you did try to bring it down, you would have the gingival margin showing, and that's not a good look. So I made the case more predictable at a certain point by eliminating the exclusion, and I left that. Now, the patient wants to have a bonding, which I actually put in her head because it will really look great. Now, maybe you have to a little bit do some enamelplasty on the point of the canine. You do not have to bond back here. Now, I think you do great bonding. I know you do some veneers as well. But for an isolated area, this is not very stress-bearing. She doesn't have a heavy bite. It's certainly not a deep bite. This should last a long time. And I have to be honest, even though I'm a specialist in orthodontics, obviously, I will occasionally do a little bonding, just like general dentists do a little Invisalign. And I actually have a cool technique. Now, you probably don't need this. You can just freehand it. But what I do is I take, print out the cast. And I can do this for you if you want. I print out the cast. Then I don't use wax because it would heat. I use the actual resin. and I lengthen the tooth as if I was doing bonding on the cast. And I really form it nice and evenly, especially on the palatal where it's tough. Then I make a suck down over that. And the beauty of this is that you're using that as your stent to do the bonding. And then that serves as the retainer afterwards. So you don't have to scan the mouth for it. So if you want, you can certainly just bond it the way you normally would. We do a scan of the mouth and I make a retainer within a few days. But this is an interesting technique if you want to try it. I could actually bring the cast down to you. You could take composite. It would be like back in the dental lab in dental school. And then it's pretty retentive because it's really getting forced on the teeth, and you cure it and you feather it all in. Let me know if you want to try that. You certainly don't need to, but I really want you to know that the bonding would be super helpful for this patient cosmetically to match sort of what the other side is. And also, I leave a lot of spaces in cases, not just intraocclusal, but in spaces like this. I don't think we need to leave it here because this canine would just clash against that. But I do it because I'm sort of like the structural engineer. I think of myself as an orthodontist, and sometimes the facade of the building needs work. So I think this is the way to go. Let me know your thoughts.